This is not an easy topic. And I think the theme of today's talk is really that as the doctor, I am only one very small piece of the team. How many doctors are in the room today? Yeah, we have a few doctors, okay? But I think it speaks volumes that everyone else in this audience is not a doctor. We are just one small piece of this. This is a hard topic, and it's a really hard topic as a doctor. My expertise as an internist is to diagnose the undiagnosed, right? To figure out a problem that comes in undifferentiated and figure it out from scratch. So that's what I'm going to share with you today, how you can be a partner with your primary care doctor to help you or your loved one get a right diagnosis. And a couple of social disclosures. You mentioned the age of 50. That's coming up for me in February. I'm really excited about that. 23 years of marriage, 2 teenage sons, and thank God both of my parents are alive and well, and I am not in the role of being a caregiver. So when I hear and I work with patients who come in with patients who are suffering, I listen and I just learn as much as I can because I realize I am not the smartest person in the room at that point. I need to understand what they're going through so that I can help them with my medical expertise. So those are my disclosures before we get started. Today what we're going to do is hopefully do 3 things, right? We're going to recognize the fact that dementia is a syndrome. It's not a diagnosis. I tell my residents that all the time, right? There's so many things that could be at play, and we need to tease it out. We're going to understand the importance, again, of the multidisciplinary team and partnering with community organizations like Alzheimer's Community Care, like the Area Agency on Aging. I saw they had a booth out there, right? Like the FAU driving school, you know, when that becomes an issue, right? So partnering with community partners. And then finally, to appreciate the fact that, yeah, you got to take your medicines, but are you taking too many? And is it time to pare things down and figure things out together? So that's what we're going to talk a little bit about today. I think no talk about Alzheimer's is complete without reminding us of the fact that this silver wave is upon us, right? And the more I think about this, the more I realize, wow, you know, what a challenge we're going to face as a country. I'm reading Doris Kearns Goodwin, her new book, which is phenomenal. She's an amazing historian, and I'm blown away by what happened, you know, during JFK's time and Lyndon Johnson's time and becoming politically active, right? This is where we need the smartest people in the room to figure out how we're going to solve this problem. We need more caregivers out there, and caregivers need to be incentivized to be able to do that, right? So hopefully smarter people than me will figure that out. But the wave is coming, and it's here. And so, yeah, it's all about the money, right? We know that this is going to be a very costly problem. It already is, and it's going to continue to be. So we need to put resources towards it. And part of the problem is that we need to figure out how we're going to solve the problem earlier rather than later. A lot of us in this room are part of the sandwich generation, right? There's always a sandwich generation. There's always a group of individuals who have young kids at home, teenagers maybe like me, with older parents who are going to be suffering with disease. And so this is the group of people that, you know, we're going to be focusing on. And so like many diagnoses in medicine, right, the earlier we can catch a disease, the more effective we could be at changing its trajectory, right? Whether it's hypertension, diabetes, heart failure, as soon as we can name it and tame it, then we're ahead of the game, right? And that's the key. And if you look at this slide, right, dementia is, you know, it's happening way, way earlier. We heard so many great things this morning about the importance of, you know, social gatherings and music therapy and taking care of your brain health with good nutrition and all of those great things. But by the time we actually diagnose it, we're usually way too late, right? And unfortunately, and I know there's amazing people in the room working on Alzheimer's research to figure out maybe one day a cure, you know, to pull those, you know, if you're here to talk about tau proteins and all those cool things, I'm not the expert on that. We're not going to talk about that today. But maybe one day we'll figure out how to pull those things out of the brain and solve it. But for now, all we can do is try to do this up front, because the longer we wait, we know that the quality of life, the financial burden, the cost is just going to continue to rise, right? So what could we do as a team of caregivers and primary care providers to get a diagnosis early, and that's what we're gonna kind of focus on a little bit today. Fewer than 50% of patients are gonna actually receive a formal diagnosis. A lot of people are just unaware. Oh, they're just, that's just old age, right? That's what happens. Mom's just becoming more forgetful, right? 6.5 years, maybe even longer before we actually diagnose it. And by the time significant impairment in function is happening, it's already too late. And so that's really, the key. We often, it's often, times when I work in a hospital and I have a patient admitted for pneumonia that suddenly, what's their baseline function here? And it's the son from New York that comes in who has no idea, hasn't seen mom in maybe months or years, and wow, what a striking change. And now we're first diagnosing it. What a difficult time to do that. So really, it all should start in the primary care's office. And so I had a great teacher in elementary school, Miss Aquilina. I'll never forget her. And she always drove this into us. Time is of the essence, right? Don't waste time. This is a graph, and so many of you, I'm going to pull back the sheets behind what goes on during a doctor's visit, right? A lot of you might not realize this, but you probably feel it, right? When you look at how much time a primary care physician spends with a patient, you can see that most of the time it's somewhere in the range of 10 to 15 minutes. 10 to 15 minutes. Now, you might have some of those concierge folks who can sit and spend a little bit more time, or maybe the doctors that, enjoy what they still do and want to spend the time with their patients. But you got these guys who are spending less than 9 minutes. How in the heck can you get anything done of importance in that period of time? And so I'm not here to make excuses for why primary care is failing this, but I'm here to talk to you a little bit about it. So here we're going to pull back the sheet so you can see a little bit behind, because we only have 1 or 2 doctors in the room. I want to share with you what goes on during that visit, and maybe ways that you as a caregiver can help partner with the doctor to make that time more efficient, right? Time is of the essence. Let's talk about this. Before the visit even begins, the doctor is spending time reviewing the chart. That patient might have a ton of chronic diseases that we have to look at, looking at labs, looking at imaging, looking at consult notes. We're doing a good chart review, so maybe it's a 5-10 minute chart review before I even step in the room. And remember, I have other patients before that, so I'm trying to figure this out in between. Now, during the visit, what do I have to do? It might be the first time I'm seeing the patient, so I need to build rapport with them and their family, right? I have to respond to their chief complaint. No one comes into the office and says, I have dementia. That doesn't happen. That would be too easy, right? But they come in with a myriad of problems that I have to differentiate. So they might come in with knee pain, but I quickly realize that we got more than knee pain going on here today. The medical reconciliation, right? We're going to talk a little bit more about that later, because that's one of my learning objectives today. But that is really important. So when a patient comes in and doesn't even know what medicines they're taking, that is a real problem, right? So doing what you can to have all that information at the ready. Then I have to take a history. I have to do a physical exam. I have to do some counseling and education. I have to have time for questions and answers. And guess what? After the visit's over, I'm not done. I'm still not done. Because now I have to think about what tests I need to order. Maybe I need to order some labs, some imaging, some consultations. I have to prescribe medicines, make sure it goes to the pharmacy. I might have to fill out a prior authorization for a medicine, right? And then I have to document the encounter. So that's what I'm doing in my pajamas at night after the kids go to bed. So I'm not here to say, oh, woe is me, woe is the doctor, right? But there's a lot going on in that visit. So when you come prepared. And so I'll give you some ideas on how we can do that, right? This is the most challenging visit, right? They come in by themselves. I might already know that patient. I might already be worried about their cognition. Maybe there's some clues that I'm picking up on over the course of the last few months that are cluing me in that maybe I'm dealing with a dementia syndrome here, right? Is this just normal? I lost my keys. I misplaced my keys. I forgot, these things. Or is this really a problem? And that's when I have to put on my detective hat. And that's where I make my money, right? So the clues that something is amiss. Suddenly, someone who's had well-controlled hypertension for 10 years suddenly comes in the office and their blood pressure is 180/90. That's odd. Or their diabetes, their A1C has been 6.5, which is really good control, right? And all of a sudden now it's 10. What happened? Or their heart failure is suddenly markedly out of control, right? So that's a clue. It may not be just, the medicines are not working. It could be that there's something going on in the home. All of a sudden, unexpected weight changes, right? Is this cancer that I'm missing, or is this just someone who's forgetting to eat? What's going on at home, right? So sudden weight changes. Missed appointments, right? All of a sudden, or frequent calls to the office for reminders of things, right? I get a call from my nurse saying, this patient's been calling a lot. I'm a little worried about them. Wow, that's a clue that maybe I need to focus on this at the next visit. Motor vehicle accidents, right? All of a sudden, more falls at home or motor vehicle accidents in the community. Or even the best is when I do get that phone call from the loved one who's away and saying, I am really worried about mom. That's probably, it's already too late at that point, right? But that's a clue. And then as a doctor, I have to use all of my senses, right? Sometimes the way a patient smells might be a clue that they're forgetting to bathe, right? You mentioned that this morning, Tino. Or their nails aren't as well as they, aren't as kept up. I always tell my residents, take off the patient's shoes when they're in the hospital. You can learn a lot by looking at people's toenails, right? Are they well kept? Looking at people's teeth, looking at how they're caring for themselves. So these are just the clues that I might need to employ some screening techniques here to pick up on a diagnosis. All right, we talked about medications, right? And I'm going to focus a little bit more about this now. Having an accurate medication list is of the utmost importance, right? Are they taking too much of something, or are they not taking enough of something that they were taking chronically, right? That could be, this could be easily fixed, right? This might not be the end stage of dementia, right? This might be just a quick delirium that we can figure out. Are they withdrawing from their benzos or alcohol use, or are they overdosing on some different medications? Now, I'm not going to bore you with the list of medications that can do it. I'm going to show you something really, interesting later, but collateral information is key, right? So I might have that patient in the room. I don't know what I'm taking. I think it starts with an L. It looks pink. Okay, listen. All right, I'm going to call the pharmacy, and I'm going to have my medical assistant call the pharmacy right now and figure out all the drugs that you've picked up in the last 3 months. That's a good start. Maybe even a quick home visit. I've done that before, where you actually go into the medical cabinet and you see, holy cow. And you see medicines, you've all done that. You're laughing like you've done this before. Holy cow. And my name is on half of those things. Oh my God. And now I'm in big trouble, right? This is how you help, right? So sometimes it's calling the family, could you please go into their medical cabinet, right, to go look at these things. Bring in your pills with you so we can put them out on the table and go through them and get rid of things that are just not appropriate. So that's cool. So this is the laundry list of medicines, right? And there's a famous list out there called the Beers list, if you're interested in looking it up, right? It's a laundry list of medications that are thought to be no-nos for the older population, right? But a lot of the drugs on that list are very helpful for patients who need them. We just have to be really mindful in how we use them. But I'm going to draw your attention to a few of these drugs that are, some of them are just over-the-counter medicines that you don't even realize that if you don't ask people if they're taking it, you're going to be lost. The 81-year-old woman who takes her little Benadryl at night to go to sleep, that could really mess with your memory. The anticholinergic properties of that drug could really mess you up. Some cough medicines, over-the-counter stuff. Obviously prescribed benzos, narcotics, neuroleptics. These are the most common things. So understanding why is a drug being prescribed, and do I need to continue to prescribe it? Is the risk worth the benefit, right? And oftentimes as an internist, I'm only one of 5 doctors that are seeing that patient. You know the story. They go see their cardiologist, they see their endocrinologist, their psychiatrist, and by the time they come to me, they might have 5 new medicines that I'm not aware of, right? What a joke. So really taking the time, doing a good med rec, and I try to teach this to our residents, so hopefully the newer generation of doctors will be more savvy about doing that. But it takes time, and as you saw, that's what we're fighting against, right? All right, so I said if you can name it, you can tame it, right? So we have to be able to make a diagnosis in order to be able to do anything about it, right? So that's what we're going to talk a little bit about now, is how do we make the diagnosis, right? So you had that slide up on yours, Tina, right? That's a great one that's a great one. So really the definition of a dementia syndrome, right, involves two things, and I'm preaching to the choir here, you know this: cognitive impairment plus some impairment in the instrumental activities of daily living, right? It's not just enough to say, oh, I forgot my keys, but you're a high-functioning executive who's paying all the bills, driving to work, and managing a household. You probably don't have dementia. Rule of thumb, what I learned from one of my neurology colleagues is this: if a patient complains that they have dementia, they probably don't. If their family complains about it, they probably do, right? That's just a clue, right? And I'll share with you some stories of patients where sometimes that might or might not be true. All right, this was the artist formerly known as Prince, and now the DSM-5 now has a whole new name for dementia, right? We're talking now about neurocognitive disorders. And so they want to bucket it into these, kind of things. Neurocognitive disorders is a complex interface, and this is why I love it. This is why it's the internist's dream, right? It's a complex interplay between neurology, medicine, psychiatry. It's a great disease to teach about and learn about and practice. But we talk about three different kinds of cognitive disorders, right? Delirium, which, as you may or may not know, is something that's acute. And it's quickly, it's waxing and waning, right? It's dangerous. It's high mortality, especially when someone's in the hospital. So that's its own separate category. Are you dealing with just a delirium? Are you dealing with a major neurocognitive disorder, and that's where dementia falls in? Or are you dealing with a mild neurocognitive disorder, what we previously called mild cognitive impairment, right? And that's the beginnings. That's where we need to find folks, right, in their 50s and 60s. Right before. And I remember Karen Gilbert, who invited me to speak, and I think she did it because I've always invited her to speak to my residents. So I'm paying her back. But she always would teach, to the residents the importance of early screening. She even did a project for her doctoral thesis in my office where she proved that she can implement an easy screening with a BIM survey to figure out, if someone might have some mild cognitive impairment. So we're going to talk about some of the screening tools that are out there. It's an alphabet soup. Some of you who are in this game probably know these things, right? And you're looking at this going, oh my God, where am I going to start, right? Which tool am I going to use? Am I going to go to Montreal for the MoCA? Am I going to do the mini mental status? I'm going to have them drawing clocks all over the place. What am I going to do? Which one of these is the best thing to use? I don't know. So in preparation for this talk, I started reviewing the literature a little bit to understand it. Is there some science behind it? And so there is. There is some science behind it. Some of you may be familiar with the terms sensitivity and specificity. Let me explain it to you in very quick layman's terms, right? The best test for screening is one that is 100% sensitive, meaning that if it's a negative test, you can rule out the disease, right? If it's positive, it doesn't mean they have the disease, but you want to now dig in a little deeper. A test that is 100% specific is if it's positive, you have the disease. If it's negative, you're not sure yet. So the best tests are obviously ones that are 100% sensitive, 100% specific. There really is no such test in the world. So this is how some of the tests that I listed up there fall on this category. So some would argue the mini mental status may be, okay. The modified mini mental status, the MoCA maybe being the most sensitive. The rule of thumb, though, after reading all about this and trying to figure it out, is the bottom line is just do it. Use whatever tool you want. Just do it. And if you're still not, satisfied, maybe you still have an idea that something's amiss, do a different one. Right? Do a third one, right? Because the more you do, the more sensitive the test will be. So as I was always taught, the best test that can be done, let's say, for colon cancer screening is the one that the patient will actually do. So whether they agree to do the colonoscopy, great, that's the gold standard. But if they're going to do a fecal occult test, then that's okay for them, as long as they're doing something then we're gonna beat that curve. We're gonna pick up more people with the disease. Does that make sense? So dementia is an umbrella term. We've talked about this. It's not a diagnosis, right? It's a syndrome that has a myriad number of causes, right? Tino touched on a few of these today, where he's been in a room with people with all different kinds of dementia, and they all behave a little differently, right? So there's Alzheimer's disease, which is probably the most prevalent. And you know, unfortunately at this point, although with some of our research folks in the room and maybe with PET scans becoming more available, we'll probably be able to diagnose it more definitively. But right now, Alzheimer's is kind of our diagnosis of exclusion, right? We usually try to diagnose other things before we say, okay, I think it's Alzheimer's, right? But for the most part, that's the most prevalent. Patients could have vascular dementia, folks that who've had multiple strokes over their lifetime, maybe not even knowing it, but who've had some chronic vascular changes in the brain. They might start having memory loss that deals and impairs their ability to take care of themselves. You know, patients with frontotemporal dementia who have, you know, just, you know, some personality changes and cognitive problems, right? Then, you know, that's a different beast. Lewy body dementia and Parkinson's disease. And then some of these other more rare things that might be associated with things like HIV disease or, you know, Huntington's disease or, you know, vitamin deficiencies, right? Some of these are more rare causes. But, you know, it's just an umbrella term, and as the internist, we have to kind of tease it all out. You hope for a quick fix, right? And, you know, 10 to 20% of syndromes that I see come in actually are reversible, which is, you know, great. And they're acronyms that we use in medicine to help us remember things. So dementia is one of them, or dementa is one of them. So again, looking at the drugs, is there an easy drug that I can take off that might, you know, clear up this cognition? Do they have an endocrine problem? Is this undiagnosed thyroid disease? Is this adrenal insufficiency, right? There's so many things that could play into, you know, abnormal cognition. Are there electrolyte abnormalities, metabolic problems, low sodium, magnesium, calcium? All of these things could play a role and be a, you know, part of something totally different that's completely curable. Am I dealing with pseudodementia? You might have heard that term before, right? Someone with depression might actually have cognitive problems. It's one of the diagnostic criteria for depression. So doing a good screening for that is important. B12 and folate deficiency, it's an easy thing to check for. I don't know if you realize this, but many of you who care for patients who have diabetes and are on metformin, which is probably the most common drug prescribed, that actually can lead to a B12 deficiency over time. And so it's recommended that we check that level pretty frequently when patients are on metformin. So that's an easy thing to find. You know, one of the reasons why, and we'll talk about the testing that should be done in all patients before we say, I think it's Alzheimer's, looking into the brain itself. Are we dealing with someone who's got God forbid, a metastatic disease to the brain, or a primary tumor in the brain, or some other mass in the brain, or some infection in the brain? That would be, you know, really important. And finally, you know, just chronic use of alcohol, and are we just dealing with, you know, a diseased brain? And then finally, here are your irreversible causes, at least for now. Maybe one day we can say that it is, you know, reversible, but you know about some of those diseases. So at least a bare minimum workup, and I know this is, again, an alphabet soup. For those of you who are not doctors, you might take a picture of that and just make sure that your doctor orders these tests, you know, after you leave. But a comprehensive metabolic panel will take care of your electrolytes, a blood count to make sure you're not dealing with, you know, anemia or a blood cancer, a TSH test for thyroid disease, B12. Don't forget, some of these STDs, like HIV and syphilis, that's what an RPR tests for. This is someone who may have had, you know, a life before, you know, when they were in their 20s and 30s, and don't remember that they contracted syphilis. And now, 30 years later, they have neurosyphilis. I've seen that before, where you can treat that, and suddenly the cognition improves, right? It's rare, but you'd hate to miss it. So you talk about that. And again, finally, the MRI of the brain, right? Looking at the brain. Really, you should not be diagnosing someone with dementia unless you've done this bare minimum workup. And then you can have some of the zebras. I always teach my residents, you know, if it sounds like a horse, you know, it's probably a horse, but sometimes there are cool zebras out there. So, you know, is this a vasculitis? Is this sarcoidosis in the brain. Is this some weird infection? You guys heard about this guy in the news probably, right? This guy had a brain worm, neurocysticercosis. This is RFK Jr., right? And so finding that was a big deal. It's one of the most, it's actually the most common cause of seizures worldwide. It's a tapeworm that you can get through the ingestion of infected pork, right? So, maybe not just dementia. All right, so now what? So now and I didn't mean to put that picture after RFK Jr. I'm not political in any way. But now what, right? Maybe you've done all the testing. You've tried to figure it out. Now you got to figure out what are you going to do. And I think that's, where you all come in, right? Where I pick up the phone and I call Karen and I go, wow, I need this family to be in your Alzheimer's community care like today. And I need a caregiver in the home. So Tino, can you help me out, right? And just tapping into all these amazing people in the room is what this conference is all about. I get chills thinking about just being a part of this community, right? And again, I'm just one small, little, tiny part of it. So again, partnering early with your community, making a referral, right? I'm not the expert. Maybe there's something that my neurology buddy, partnering with a research organization, can actually get you enrolled in a trial, right? Let's do it. Let's get you in there while we have the mild cognitive impairment. You're worried about your loved one. Let's enroll them in a study. Let's get them in, right? So there are things you can do. You're worried about your loved one driving. Let's get them down to FAU and get them tested. Get a formal report so we can prove to each other that it's safe or not. And most likely it's not. So that's a real helpful thing to do. Regular family meetings, right? Once I've picked up on this in the office, this is when I'm going to say, you know what, for the next visit, I think you should bring your loved one. And if they're not local, let's do a FaceTime, right? We have technology. There's no reason why we can't get people on the phone or on a computer screen, right? Or, hey, let's go visit at the house. And, I've done that and gotten the deviled eggs and celery sticks. Those are great. I love doing that. It's fun. And you learn a lot by being in the house, right? Other things to consider with your patients who maybe have already gotten the diagnosis, and this is what I call a little lagniappe. Anyone know what that means? Hopefully my friend from Tulane knows what lagniappe is. Lagniappe, what is it? You know it? It's a little something extra, right? It's when you get a bowl of turtle soup at Commander's Palace and they put a little extra sherry in it. That's called lagniappe. So I'm giving you a little extra now, right? We've already talked about how dementia is not a diagnosis. We've talked about polypharmacy, but I'm going to give you a few other things to consider with patients with dementia. How do you care for them when they're hospitalized, right? And then what about advanced care planning? I think no good talk can go without making sure we understand a little bit more about this important topic. So number one, when your patient is hospitalized, your loved one is hospitalized, this is what I call the low-lying fruit to make sure that their experience in the hospital doesn't deteriorate into something worse. They came in for pneumonia and they leave with a hip fracture because they were delirious. You know that one, right? It's sad and it happens and it's preventable if we just take some easy steps. Simply having that orientation board just so they know what the day and time is. When I come into the room in the morning, I open up the shades. It's daytime, right? It's like what I do with my teenager at 10 a.m. It's time to wake up, right? So this is something that's easy to do. Day-night reversal happens and they get that, sundowning and get delirious in the hospital. Does your patient really need labs at 2 in the morning? Could we give them a break? Maybe no vital signs from like 12 to 6, give them that time? And you can put that, as a doctor, I can put an order in the chart. It's the only place in my life where people listen to me, is in the hospital. At home, nothing. Mobility, right? Getting patients out of bed sooner rather than later. It doesn't always have to be a formal physical therapy referral. As part of your exam in the morning, you get them up out of bed. It's easy enough to do, right? Making sure they have their glasses, making sure they have their hearing aids, right? Making sure that they get get food while they're there. Very easy. And then encouraging family members, obviously not everyone is going to be able to afford a personal care attendant to be in the hospital, but taking turns with your family to come and visit and stay with them, especially if you can do an overnight shift, because that's when things really go south. So just some helpful hints that you can do as a caregiver to help your loved one if they're hospitalized. Oh, the stethoscope trick is a good one. That's, if their hearing aids aren't there, you can actually put your stethoscope in their ears and talk into it. It works. It amplifies the sound. All right, so final talk about patients' rights and how this is not about death panels at all, as she might have led you to believe. But advanced care planning is of the utmost importance in all of us, right? We should all have an advance directive indicating who's going to make our decisions if, God forbid, we can't, right? But even more important in someone who we've now diagnosed with maybe early stage dementia, and before things start really going downhill, having this conversation early and often, right? The time is now. If you haven't read, any of these books, I highly encourage you to do so, especially When Breath Becomes Air and Atul Gawande's Being Mortal. This book is very boring. It's put out by the Institute of Medicine. It's very thick, and it just talks about how awful we are at doing this in America. The Conversation Project, for those of you who are struggling with ways to have this conversation with your loved one, that's a great tool to tap into and have some scripts to talk to folks about. Because as you age or face a serious illness, right, who's going to make your decisions, right? And for me, what's it based on? It's based on what that patient believes and what's important to them. So you really have to have conversations. I loved hearing our talk this morning about just the importance of tapping in to what makes them, right? Wow, you were a music teacher and that's your thing. Wow, that was easy to figure out. What did that take? That took all of 5 seconds to figure it out, and it changed the trajectory of that woman's life, right? So what's important to you? And what happens when you lack capacity? Who's going to make your decision, right? It's really cute, right? So those are going to be my healthcare surrogates one day. Probably more this guy than this guy. They're now 15 and 13, so I'd probably trust him more than him so far. He's got that look in his eye, right? But they're all awesome, right? So, but you know what happens, and I have some guardians in the room that I know are facing a real issue. And I told you I was part of the ethics committee at our hospital. Guardians who are appointed as the decision maker in end-of-life issues now have to go in front of a judge before they can actually act on someone's DNR order. Ugh, that is really slowing things down and putting patients in the last stages of their life through some real tough times, and that's sad. But if you don't make a decision for your loved one, the law is just going to decide for you who's going to make that decision. And that patient might not want their son from New York making the decisions. There might be some bad blood between them. So really important to encourage them to have the conversation with their primary care doctor, to just designate a healthcare surrogate, talk about your wishes. It should be something that's done during the annual wellness visit. We talked about how time during the visit is of the essence, right? The annual visit, typically we have a little bit more time, right? So that's when really these things should be brought up. But we can talk about it at any time. Living wills could be written, they can be oral declarations, but this is what most people do, right? They just bury their head in the sand and they just go, I don't care, right? So I think I have time for a few stories. I haven't seen we're gonna have time for questions and answers in a few minutes. I have 2 minutes, see, perfect, right? I have this down to a science. And I have to do this again at 11, so I'll get even better at finding the time. I just wanna tell you a few stories about these folks here. Carol's a 51-year-old woman. She's a radiation tech, super smart. She's got a British accent, and she was a nanny, right? Can't make that up. She's well-controlled bipolar disease for 15 years, on her meds, doing great. Decides that, with her doctor, that she's going to go on the new weight loss drug, right? She goes on Ozempic. And over the course of a few months, she's losing weight, she's feeling great, everything's going great. And then I get the call, I think I'm losing my mind. I can't remember anything. I woke up in the middle of the night, and I didn't recognize who I was. I didn't know where and I went to my psychiatrist. They lowered my drugs. They thought maybe my weight loss, maybe my dosing was off. They lowered my drugs, and she was distraught. Holy cow. Am I dealing with dementia? Is this early onset dementia at 51? Probably not, right? Early onset, acute onset, probably not. I do all the workup that I'm teaching you about, right? MRI, CMP. all the blood work looks great, but her MRI shows some bilateral changes in the brain, that maybe she's had some, vascular changes over time. She's getting worked up to make sure she doesn't have atrial fibrillation, that maybe she's throwing clots to her brain. She got back on the right dose of the psych meds. She got off the Ozempic, and she's slowly improving, right? But, that was a scary one right there. But again, could it be dementia? Maybe, maybe not. But I got to be a detective to figure it out. Here's Fred, right? Oh, such a sweet man from Maine with his wife. He comes in. I knew him for 15 years. He recently passed away. And when I first met him, he was the jack of all trades. He could fix anything in the house. But over the course of a few months and years, the wife would come with him to the visits and say, something's changing. And sure enough, he was on that trajectory. That was clearly an Alzheimer's. That was probably a mixed picture. He had vascular changes on his MRI, but he was, at the end, really, really far off. But the conversations that we had made it so much easier for her to come to grips. She was an amazing caregiver. Hopefully, she got to meet some of you in the room today. And then there's Les, right? 65-year-old, lost his wife, at the age of 55 to a dementia syndrome. Kid you not. And then he comes in with, his daughter every time, and, she's worried about his memory. We diagnosed him with frontotemporal dementia. That was a really sad thing. And he's doing well now. And he's still, he's still with it enough to call me every once in a while, so I enjoy that. And then there's Angelica, right? The Italian 81-year-old from Palm Beach who's got everything in the, hoarding everything in her apartment. She's got the daughter from Italy who comes in every once in a while. She was full-blown Alzheimer's. We ruled out everything else but that. But just sweet, names and stories that remain in my memory and help make this real for me. Hopefully it makes it real for you. I know what you do every day is super meaningful. Thank you for allowing me to be here. I think now we have time for question and answer. And Carol, I want you to be the first one to ask a question. Yeah, I always try to teach this that, how many of you have cared, when you guys go and care for your loved ones and your caregivers, how many times does your patient not have a pulse and they're not breathing? Does that happen a lot? It doesn't, right? So knowing someone's code status, whether or not I should do CPR or not, only makes sense if they don't have a pulse and they're not breathing. So I think the code status is just one tiny piece of the puzzle. I'd rather focus on all the other parts of the pulse. For those of you who are familiar with physician's orders for life-sustaining treatment, I'd rather think about how do I treat that person when they're alive and they have a pulse and they're breathing. Am I taking them to the hospital? Can I care for them in their home? Do they want, an airway if, God forbid, they couldn't breathe? Do they want, IV antibiotics? That's, I think, more important than the code status. Some patients bring it up to me, and they have really strong feelings one way or another, and I'll honor their wishes, making sure they understand and have an informed decision. But it's not usually the crux or the focus of my discussion. Does that make sense? In the hospital, it's a little bit different. Patient comes in, and they're 85, and they have pneumonia, and I'm thinking there's a possibility things might transpire. I might want to know sooner rather than later, hey, if this is going to happen, oh, no, I wouldn't want CPR. So sometimes I'll bring it up in that case.
We are so grateful for Dr. Bagatell's presentation. We take this opportunity to emphasize some of the very important points in his presentation. It is most important to understand that dementia is not a diagnosis, but rather a description of symptoms in the two domains that Dr. Bagatell mentioned. These are failure of memory and difficulties with the instrumental activities of daily living or executive functions. These include driving, paying bills, preparing a meal, programming the washing machine, and so on. When a person is having difficulty in both these domains, we say they are having symptoms of dementia. This does not necessarily mean that they have Alzheimer's disease. Dementia by itself is not a diagnosis, though all too often we hear that a loved one was diagnosed with dementia. We would not say someone was diagnosed with coughing, Coughing is a symptom. We count on our healthcare professionals to find out why we are coughing. Is the cough due to a short-term minor illness, a medication side effect, or a more serious medical condition? The same analysis should apply when someone exhibits symptoms of dementia. We now know that there is a variety of treatable causes for symptoms of dementia, regardless of one's age. Clinical depression is common as we age, and if undiagnosed and untreated, symptoms can mimic those of dementia: foggy thinking, inability to concentrate, difficulty accomplishing typical activities of daily living, and so on. Infections that are common in older adults include urinary tract infections, pneumonia, and COVID-19. Patients often do not have fever, and the infection can be missed. When behavior or mood change suddenly, or cognition suddenly worsens, the possibility of an emerging illness or infection should be considered and evaluated by the patient's physician. If a person is dehydrated or malnourished, he or she can also exhibit symptoms of dementia due to resulting electrolyte imbalance. If you ever had an illness that produced vomiting and diarrhea, you may recall feeling that you could neither concentrate nor accomplish routine activities of daily living. Underactive thyroid or hypothyroidism is also common as we age. If untreated, the patient can experience confusion, mood disorders, and cognitive impairment. Vitamin deficiencies, particularly deficiency of vitamin B12, can result in symptoms of dementia. After age 50, adults may not efficiently absorb vitamin B12 from food. A vegan can experience B12 deficiency at any age because the vegan diet lacks animal products. Rising blood sugar, as when a person is developing type 2 diabetes, can lead to changes in mood and cognitive dysfunction. Brain tumors or lesions can also produce symptoms of dementia. When treated, the symptoms of dementia may resolve. Exposure to toxic chemicals, such as pesticides, paint, or cleaning chemicals, can also produce symptoms of dementia. Cognition may recover if the patient is removed from such exposure. Providing a history of exposure to chemicals is important for identifying potential causes for symptoms. Identifying the specific exposure and the extent of exposure may lead to an effective treatment. Menopause can result in hormone imbalance, resulting in problems with concentrating, learning, and retaining new information, and forgetfulness, symptoms of dementia. Without evaluation for hormone imbalance, the patient may be assumed to have Alzheimer's disease or a related disorder. Any prescription or over-the-counter medication can produce side effects or interact adversely with another. This same can be true for over-the-counter supplements, vitamins, minerals, herbals, and the like. It is most important that the healthcare provider see all prescription, over-the-counter, and supplement bottles to evaluate possible undesired effects on cognition and physical abilities. The label on each bottle provides information that would not likely be a simple written list of medication names. Many adults are adversely affected by polypharmacy, the use of multiple medications for one or more medical conditions. The more medications a person takes, the more likely it is to experience side effects, drug interactions, and more. Polypharmacy is recognized as a growing concern for older adults. As we age, our liver and kidneys are not as efficient at breaking down medications, which is the job of the liver, and excreting the byproducts, which is the work of the kidneys. This means that the byproducts of medications we take may accumulate in the body and potentially cause symptoms of dementia. It is estimated that delirium is missed as a treatable diagnosis more than 50% of the time, and according to some sources, up to 80% of the time. It is often mistaken for symptoms of dementia. Delirium should always be considered when there is an abrupt onset of deterioration in behavior, cognition, or functional ability. When someone is acutely ill or hospitalized for illness or surgery, It will likely be the family caregiver that advocates for consideration of delirium when abrupt changes in the patient's cognition and/or behavior occur. The caregiver knows the person's usual demeanor, cognition, and ADL abilities, among others, and is in the best position to identify an abrupt change. Symptoms may diminish or resolve altogether when these conditions are treated, and it always makes sense to treat earlier rather than later. Regardless of one's age, a primary care physician should always evaluate for treatable causes of symptoms of dementia. This is because cognitive impairment is not an inevitable consequence of aging. All too often, an older adult is assumed to have Alzheimer's disease or a related disorder when symptoms of dementia emerge, merely based on age. If no treatable conditions are found, or if after treating a treatable condition, cognition does not improve, a prompt consultation with a neurologist specializing in neurocognitive disorders, such as Alzheimer's disease, should be scheduled. These neurologists can best identify which neurocognitive disorder is likely present, if there is more than one disorder present, and is the specialist best prepared to offer possible interventions and clinical trial opportunities. It is important to note that the only clinical trials resulting in a slowing of Alzheimer's progression were those involving patients in the early stage of Alzheimer's disease. Therefore, early intervention is vital. This list illustrates that while Alzheimer's is the most prevalent irreversible neurocognitive disorder, there are many others. As you see, these other disorders can develop at far younger ages. Here we emphasize again that it is most important to disregard age when trying to evaluate if someone has a neurocognitive disorder. The Alzheimer's Association reports on studies that suggest that more than 50% of people with dementia studied at Alzheimer's disease and research centers have more than one cause for their symptoms. This is referred to as mixed dementia or mixed pathology. The most common combination of disorders is said to be Alzheimer's and vascular dementia. Alzheimer's disease may also coexist with Lewy body disease. Patients can have more than two pathologies at the same time. In a study of 1,000 volunteers conducted by the Rush Alzheimer's Disease Center in Chicago and reported by the Alzheimer's Association in 2022, it was found that 78% of these 1,000 people had two or more pathologies, 58% had three or more, and 35% had four or more. The risk of having mixed dementia increases with age and is highest in those age 85 or older. The possibility of having more than one condition producing symptoms of dementia underscores the importance of evaluation and diagnosis by a neurologist specializing in these disorders. Screening for cognitive impairment is neither standard nor routine in primary care settings. Alzheimer's Community Care created this logo with a goal of inspiring standard, routine cognitive screening, just as the other vital signs, such as pulse, blood pressure, respirations, temperature, and pain, are routinely assessed. We have readily accepted screening for so many conditions: diabetes, high blood pressure, breast, colon, cervical, prostate cancers, and more. With screening, conditions can be identified early when they are most treatable. Over recent decades, so many conditions that were often fatal are now successfully treated when identified early, with the quality of life and lifespan preserved. Alzheimer's Community Care advocates for this same principle to be applied to brain health. Why is emerging cognitive impairment so often missed in the primary care setting? A recent publication noted 4 main themes for this phenomenon. Primary care providers hesitate to discuss brain health and cognition. Patients hesitate to mention concerns about their cognition. Guidance for healthcare providers for developing treatment plans for cognitive decline is not communicated well. Social and cultural context for cognitive impairment affect perceptions of cognition and brain health, affecting clinical discussions with patients. In 2019, the Alzheimer's Association published its annual Alzheimer's Disease Facts and Figures report. In this report, results of a survey of 1,000 primary care providers was displayed. Here are their responses about information that would be helpful in assessing cognition. 950 of these 1,000 physicians said information on which assessment tool to use would be helpful. 940 wanted information on next steps with the assessment indicated cognitive impairment. 930 wanted information on how to use the assessment tools. 910 sought information how to implement these assessments in their medical practice. 880 asked which patients should be assessed. 880 wanted information on when to retest if the cognitive screen is normal. And 840 said information on how to discuss evidence of cognitive impairment with the patient would be helpful. Clearly, if such a high percentage of physicians have these questions, our healthcare system lacks standard guidelines or medical principles for assessing cognition and initiating interventions. In response to these survey results, we offer the following responses to each aspect. There are literally hundreds of brief cognitive screens available. It would be beneficial to identify 2 or 3 for physicians to choose from. Limiting the choices improves the ability of providers in various settings to interpret the results in a standard manner. When cognitive impairment is identified, next steps should be comprehensive evaluation for treatable, reversible causes, regardless of the patient's age, and a referral to a neurologist specializing in neurocognitive disorders who can evaluate for Alzheimer's disease or a related disorder. Narrowing the choice of assessment tools ensures that staff in medical offices can be proficient in administering them correctly. We now know that cognitive impairment can emerge in adults far younger than 65. While 95% of Alzheimer's disease occurs in those over the age of 65, other conditions can manifest far earlier. One example is chronic traumatic encephalopathy, or CTE, which occurs after repeated concussions. We know that football players have developed cognitive impairment and behavioral issues in their 40s, or some even younger. It makes sense to screen all adults. Screening also establishes a baseline against which problems that emerge later can be compared. If a cognitive screen is normal, cognition should be reassessed at the next annual exam, or sooner if the patient sees the physician for another health concern, or if the patient expresses a concern about cognition. Patients should be informed of the results of their cognitive screen. They should be informed about potentially treatable and reversible causes for cognitive impairment and offered screening and treatment for these causes. They should also be encouraged to seek prompt consultation with a neurologist and provided with the benefits of the earliest possible intervention if a neurocognitive disorder is diagnosed. Many patients receive no diagnosis for their cognitive impairment until the middle stage of their disease. As pointed out earlier, research studies have not developed any significant treatment that all patients can safely take, or which achieves significant improvement in symptoms. The only way to identify disease early, in its most treatable stage, is through screening, just as we do for many cancers, diabetes, high blood pressure, and others. Screening is referred to as secondary prevention. That is, the ability to catch a condition early when interventions can be most effective. Here, we illustrate adding a measure of cognition to the other routinely assessed vital signs. Pain was added about 30 years ago after the American Pain Association proposed that pain was not routinely assessed and thus undertreated. The same can be said about cognitive impairment. Without screening, emerging impairment is missed. If missed, no further evaluation for appropriate follow-up, referrals, and interventions is accomplished. While one's anxiety about being screened for cognitive impairment is understandable, it is most important to recognize that the research that resulted in the recently approved medications Leqembi and Kisunla benefited only those in the early stage of Alzheimer's disease. Early stage is short and easily missed in the absence of screening. Alzheimer's Community Care will continue to advocate for medical principles resulting in standard, routine screening and guidelines for thorough evaluation of symptoms, prompt referrals to specialists, and support for family caregivers. Dr. Bagatell mentioned Karen Gilbert's study on identifying cognitive impairment in patients evaluated in his office. Of 98 patients screened, 24 were unable to correctly complete the brief interview for mental status, or BIMS, the cognitive screen Dr. Bagatell mentioned. What is so important is that 5 of these patients were younger than 65. 2 were in their 50s. If the screening had not been performed, their cognitive impairment would have been missed. These patients do not necessarily have Alzheimer's or one of the related disorders. However, the low score on the brief interview for mental status leads to that search for treatable causes. At worst, if they are developing a neurocognitive disorder, this screening affords the opportunity for early intervention. We now know that the pathology that causes Alzheimer's disease, the misfolded beta amyloid and tau protein shown on this slide, starts to develop up to 20 years or more before patients ever have obvious symptoms. This means that we have the opportunity to influence our risk of developing Alzheimer's disease. Recent studies and information tell us that lifestyle choices can have tremendous influence on maintaining brain health and reducing Alzheimer's risk. If one inherits either 1 or 2 copies of the E4 variant of the APOE gene, there is a greater risk of developing Alzheimer's, but it's only a risk. That risk is believed to be minimized by adopting healthy lifestyle choices. Preventing a disease is always better than trying to treat it. This is particularly important because there currently is no cure or universally applicable treatment to modify the disease. We encourage you to explore these lifestyle strategies now believed to help prevent or delay onset symptomatic Alzheimer's disease. Recent studies have shown that patients with a diagnosis of Alzheimer's disease showed improvement in cognition and physical abilities when they changed their diet to a Mediterranean-style diet, engaged in daily exercise, and increased their social activities. Let's review these strategies and why they are important to brain health. Do not smoke and avoid exposure to secondhand smoke. Smoking damages blood vessels and contributes to type 2 diabetes, which also damages blood vessels. The health of the brain depends on good circulation, bringing oxygen, sugar, and vital nutrients to the brain's neurons. For optimal health, we need 7 to 8 hours of sleep each night, with about 1.5 to 2 hours in a deep or dream state. The dream state is referred to as rapid eye movement or REM sleep. This is when the brain cleans itself of toxic waste products, consolidates memory of new information, and generally recharges itself. Chronic lack of adequate sleep contributes to cognitive decline. A Mediterranean-style diet emphasizes fresh fruits and vegetables and high omega-3 sources, such as walnuts, tuna, salmon, extra virgin olive oil, and others. These foods work to decrease inflammation in the body. Inflammation is an underlying cause of many diseases, including Alzheimer's. Physical activity totaling at least 2.5 hours per week is recommended. This represents an average of just over 20 minutes per day. Walking is fine for exercise. Any type of exercise fosters brain health by increasing blood flow and enhancing thinking, memory, and focus. In the short term, alcohol can impair memory and speech. With long-term exposure, alcohol can cause the brain's volume to shrink, leading to cognitive impairment. These negative effects may occur in those who believe their intake to be moderate. According to the World Health Organization, there is no safe level of alcohol intake. Challenging yourself to learn new things, a new language, hobby, type of puzzle, can stimulate growth of new brain cells or stimulate new connections between the brain's neurons. This will prevent or delay onset of symptoms of dementia. High levels of stress can lead to cognitive impairment and a higher risk for Alzheimer's disease. While it is unlikely that we can change the stress coming at us, we can control how we respond. Explore activities and strategies that help you reduce the impact of stress. Certainly, getting good sleep, exercising, eating healthy foods, and engaging in a relaxing activity can all help to decrease negative impacts of stress. Staying socially active is another way for the brain to exercise. This decreases the risk of developing symptoms of dementia. Socialization benefits dovetail with some of the other strategies discussed here. It reduces stress, boosts mood, and it inspires other health choices, such as exercising and eating a healthier diet. Of course, it always makes sense to protect yourself from injury, particularly head trauma. It is vital to always wear the car seat belt, whether you are the driver or the passenger. Have a spotter when using ladders. Wear helmets for bicycle riding or skating. Using your non-dominant hand activates both sides of the brain, improving brain function by improving the connection between the two sides of the brain. Creativity may also get a boost. Studies have found that adults with Alzheimer's disease had more dental health issues than adults without Alzheimer's. Tooth loss from decay or gum disease was also linked with a higher risk of developing Alzheimer's. Daily flossing and twice a year checkups and dental cleanings are recommended. Untreated hearing loss is a known risk factor for Alzheimer's disease. Hearing loss can make the brain work harder to hear, leaving less capacity for thinking and memory. It may also lead to social isolation, brain shrinkage, and other structural changes in the brain. An audiologist can determine the type and extent of hearing loss and recommend the best intervention. Meditation is said to benefit the brain by slowing its aging. Meditation reduces stress and increases mental clarity and focus. A sense of purpose is associated with a decreased risk for developing dementia. This may be associated with greater interest in exercise and socialization, two of the brain-healthy strategies discussed earlier. Annual physicals, preferably including cognitive screening, can ensure that evidence of cognitive decline is promptly addressed to identify treatable causes, and a referral to a neurologist specializing in neurocognitive disorders is given. This way, a developing disorder can be treated in its earliest stage. As you can see, a number of these strategies overlap, working together to protect brain health. Thank you for watching this presentation. We encourage you to reach out to Alzheimer's Community Care with any questions, concerns, or for more information.